to go ahead and get started. So part one, we're going to look at the OB exam. We're looking at the environment, biometry, and then the anatomic survey. First thing you want to do when you put that transducer down before you do anything else is look for a heartbeat. Does you no good to do all the measurements, looking at everything, and there's no heartbeat. So look at that. Just look, you don't even have to do the heart rate right away. Just confirm that there is a heart beating, and then go on to your exam. You want to make sure when you're looking at a embryo, that if it's less than 10 weeks of gestational age, that we're using the M mode and not Doppler, because Doppler is a little bit higher energy, and we want to use as low as possible energy. So in our guidelines for the AIUM, they want us to use the ALARA principle, which is called as low as reasonably achievable. So we're going to use our M mode more often than not. First trimester, definitely. Second and third trimester if you can. If you can get it, then go ahead and go on to your Doppler. I also want to make sure that when you're looking at your machines, you're looking at these thermal index. So it's called TIS or TIB. That's thermal index in soft tissue and thermal index in bone. In the first trimester, you need to make sure you're using TIS. Again, it's looking at how much energy, how much heat is being introduced to this little embryo. Do not use TIB on your first trimester stuff. Make sure it's TIS. And you know, whoever your vendor is, they can come in and have this all preset. Just make sure that you have TIS for the first trimester. And it's usually up right along the top line or over to the side. It's going to let you know what your setting is. So this is a nice little first trimester. This is where we would do a nuchal translucency. And then in the second trimester, of course, it's go ahead and then use the TIB. See, even this little 12-weeker saying, no, don't use the TIB. All right, so we want to optimize our image. We want to use the 5 to 6 megahertz preferred for your survey in the second trimester. When you increase your megahertz, you're going to increase your resolution, but it does decrease your penetration. So there's always a trade-off. And the third trimester, you're going to have to go to that 2.5 to 3 megahertz because you have to penetrate all the way through to the posterior wall. Now, sometimes you're going to have a mom who has a BMI of 48, 49. You may have to use that 3 megahertz or a 1 to 3 earlier than what you would like. But again, try to always use the highest megahertz just so you can get the best images. You need to be able to adjust your depth, adjust your overall gain, adjust the focal zone, and then you always want to make sure whatever you're looking at that time, that's at the center of your image. So I'm just pointing these out because this is really going to affect what your image looks like and what kind of quality exam that you're going to get depending upon how you know how to adjust your machine. So you want to magnify or zoom when you're looking at different things. And all these machines, they're all different, but they all have the basic things. Your megahertz control, your focal zone, your depth, your TGC, which is a time gain compensation, your overall power, and then the resolution or the mag. So I'm just going to show you a couple of video clips here. The only thing I'm changing here is just the overall gain. But can you see how it really changes the whole quality of my image just by how I have my gain settings? See, not enough. Look, when it's down so low, it's hard to see. So turn it up a little bit, but then if I'm turning up the gain too much, then it gets too bright, and I'm actually losing a lot of my detail, a lot of my image quality. This one is the TGC. So it's almost like a little vertical piano that you can play, where it's just moving up and down. So you're telling the machine, what echoes am I going to listen to, and which one am I going to filter out? And then adjusting the focal zone. This is all the same patient. Look where the focal zone is set, way up here. Now all I'm going to do is just move the focal zone. Do you see how much crisper, cleaner that is? Just by changing the focal zone to the middle of the image. And then this one's down a little too far. You want to keep that focal zone to the center of what you're looking at. Okay, you're going to be adjusting throughout the scan your depth, zoom, focal zones, depending upon how the baby's moving and what you're looking at. It's not the same settings for every patient. every patient, and then even that baby, as that baby's moving around and mom's moving around, because they don't always lay still. I mean, you're going to be adjusting that. So you just have to get used to, where are these buttons on my machine? How do I make that image look better? So we want to make sure when we're using the focal zones, the correct site, the position, and then the number. Some of them will come up with, 1, 2, 3, 4 focal zones for the best detail, because the more you add, the slower it makes the frame rate. So you want to stay with the 1. When you're doing the overall, you can use 2. And if you have a bigger patient, then use the 2 so you can get the penetration. But when you're trying to look at the anatomy, try to keep it to the 1 focal zone. Okay, always optimize for the maternal or fetal part, whatever you're looking at. So you're going to do that survey in the beginning, just scanning around, but then as you're changing your depth and your sector width, then you're going to adjust your focal zone, adjust your TGC, and your overall gain. So the OB exam, what are we looking for? Where do our guidelines come from? What must be evaluated and what must be documented? So there's a difference between what's mandated and what's recommended, and that's what we're going to look at. So in 2014, AIUM guidelines, which is American Institute of Ultrasound and Medicine, and this is their website, they updated some of their guidelines. So these are the practice guidelines for OB ultrasounds. The guidelines were developed in conjunction with the American College of Radiology, American College of Obstetricians and Gynecologists, and the Society of Radiologists in Ultrasound. So all of them got together and had an input as to what the guidelines should be. They're saying that you must document fetal cardiac activity, how many fetuses there are, the presentation of each of those fetuses, and then the amniotic fluid assessment. Where is the placenta? Where is the placenta in relationship to the cervix? And then your biometry, the gestational age assessment. You're going to document the fetal weight. You must also look at the maternal anatomy. The cervix, uterus, looking for fibroids. The adnexal areas, looking for adnexal masses. And then you're going to go and look at the anatomical survey and the biometry. You must create a permanent record, and you must be using a real-time scanner. All right, so establishing the best due date. In October 2014, the committee opinion revision, again from ACOG, AIUM, and SMFM, they made these revisions or recommendations that for a crown rump length up to 13 weeks, 6 days is the most accurate method to establish or confirm the gestational age. If the first trimester ultrasound confirms your LMP date, stay with the LMP date. Don't change it for 1 or 2 days. If it's assisted reproductive technology, use the ART gestational age and use that due date. I mean, if they're doing ART and they're doing IVF, that is going to be your most accurate dating. And then once that due date is established, do not change it. So once your EDD is established by LMP or first trimester ultrasound, make sure it's documented in the record and stay with that due date. The crown rump length up to 13 weeks, 6 days is accurate plus or minus 5 days. You want to make sure that you're getting at least 3 discrete measurements. You want to make sure that the baby's not hyperflexed or hyperextended. It has to be in a neutral position, because just the way the baby's holding the body can change your CRL. In the second trimester, our measurements at best are plus or minus 7 to 10 days. And this is using BPD, head circumference, abdominal circumference, and femur length. And then the third trimester, look at this, plus or minus 14 to 21 days. So you should not be changing the dates based on the third trimester ultrasound. So guidelines for redating. If it's less than 8 weeks, 6 days by crown rump length, if it's more than 5 days, go ahead and change the dates. From 9 to 13 weeks, 6 days, more than 7 days, then change the dates. So here's an outline of when you should change them, and these are the dates. So it's very important that you take multiple measurements. Don't rely on just one measurement. All right, correct dating of the pregnancy is necessary for correlation of your lab draws and your screening. When am I going to be doing first trimester screening? When am I going to be doing a quad screen or NIPT? When am I going to be looking at all of these different things? It's also important for timing of the ultrasound anatomy survey, and then the correct timing of your delivery. There's lots of different labs out there. So this just gives you an outline. This chart is mainly for you guys to know what is the false positive predictive rates. What are their predictive rates for Down syndrome, trisomy 18, open neural tube defects, the different labs that are out there. There's many of them, and whether it's a quad screen or tetra, the triple, the penta, or just the MSAFP. So if you're doing a first trimester screen, then you're probably still also going to do the MSAFP because look, the first trimester screen does not give you a risk for open neural tube defects. So this is telling you what they're looking at. And then we talk about non-invasive prenatal testing. So this is the cell-free fetal DNA. It's found in the maternal plasma. It's a technique called the massively parallel sequencing to sequencing, or MPSS. And it looks for just an over or under representation of specific chromosomes. So this is the one where they're looking for trisomy 21, 18, 13, Turner's. And there's other labs that are looking for some other things, but those are still being studied. So out of all of these tests, the 4 main tests that we had, or sites, were Maternity 21, the Verify, Harmony, and Panorama. The first 3, those studies were all done in a high-risk population. The Panorama test was the only one that was designed for women of any age. So we're finding some of these NIPTs are coming back with a negative screen. These parents think that everything's honky-dory, I'm going to have a nice, normal, healthy baby. We do the anatomy survey. They have short, long bones. They have a thickened nuchal fold, and they have a heart defect, and that baby has trisomy 21. So just because they have a negative NIPT doesn't guarantee that they're not going to have a chromosome abnormality. So you really still need to pay attention to your markers. Okay, and these labs, I mean, they're changing so often. I mean, the advances that they're making, I mean, week by week, month by month, they're coming up with new things. So really just keep up to date on the studies that are coming out because they are changing. And your genetic counselor, if you have one that's available to you, I mean, they're wonderful to helping you assess things. Okay, looking at the OB exam, we're going to look at the maternal pelvis, fetal environment, the biometry, and the anatomic survey. So how do we do that? So we're going to do both a sagittal and transverse images through the maternal and the fetal survey. So we're going to scan midline, and we're going to look from midline all the way over towards the right, back towards midline, all the way over towards the left, and then turning your transducer 90 degrees, coming down low in the pelvis, and we're going to come low all the way up to the umbilicus and then all the way up to the fundus. So the environment's going to confirm viability, scanning, sagittally and transversely, documenting how many fetuses, what part of the baby is closest to the maternal cervix, the estimate of how much fluid is around the baby, and then where is the placenta, its appearance, and the relationship to the internal os. And then, if necessary, go ahead and look at the cervical length. We don't measure the cervical length routinely in the second trimester unless it looks short or if there's a history of a leap. And then survey the uterus and the adnexal areas. So a lot of times when I'm doing my survey, I'll just, instead of, if you have the opportunity or if you have a machine that does it, just do a clip from the right to the left. Then you don't have to stop and do all these different images. And even the little laptop ultrasound machines have that ability to store a clip. Documentation has to be permanent record of the images, the interpretation or final report. You have to document all required images, label the images correctly, right, left, document all your measurements. Final report has to be entered into the medical record. You must retain that ultrasound report, and then you have to document the results were reviewed with the patient. So we're going to look at these scan planes. And now there's a difference between when I'm talking maternal, sagittal, and transverse, and then we talk about the baby. Because we're doing our survey on mom, but when it comes to the baby, it's sagittal and transverse on the baby. So if the baby's oblique, I may be scanning oblique on the mother to get a transverse of the fetus. So it's not the same as what the maternal plane is. So when we're looking anterior to posterior, from the front of the baby to the back of the baby, then that's going to be a coronal view. Sagittal is from the head to the foot, and then transverse or axial from side to side. Remember, everything in the baby is connected. So if you're seeing a sagittal of the spine and you want to get a transverse of the heart, turn 90 degrees. Everything, you just remember, 90 degrees. That at least is going to get you in a close plane as to where you need to be. Okay, so fetal presentation is the most important step. Everything else relies on this, and you identifying how is the baby laying in the maternal pelvis. We're going to label it cephalic if the head is closest to the maternal cervix, breech if the butt is down there, transverse if it's laying from side to side, and then oblique. Sometimes they get in those weird positions, especially if mom has a uterine abnormality. They can get some very unique presentations. For orientation, until you get used to identifying how the baby's laying, either have a baby doll or a little beanie baby, whatever you want, and have it sitting on top of your machine. So you know mom's laying up there, so you know it's right side, left side. And once you see how the baby's laying, kind of turn your beanie baby, and it kind of like you can glance up and you can see what's right side, left side. It kind of helps you make that connect. So just have, you know, say, oh, well, the baby's facing down, so that's going to be baby's right side is closest to the cervix, left side is up. It's just that little visual. So if you have a little doll or something, or beanie babies, I like to use them because you can sit them right on top of the monitor, and they kind of sit there. And it just gives you that little visual. I know my ultrasound students, the residents, I mean, they have their little beanie baby they take with them on all the machines, and they use that, and it just helps them remember the orientation. So with your fetal presentation, remember, look for where the fetal spine is. If the baby is head down, the spine's going to tell you what side of the baby is down. So if the fetal spine is on the maternal right, the fetal right side is down. So if the head's down, spine's over on the right, baby's right side is down. If the spine is on the maternal left, fetal left side is down. It's just a little thing to kind of keep in your mind. If the baby is breech, then it's opposite. If the spine is on maternal right, the fetal left side is down. If the fetal spine is on the maternal left, the right side is down. A lot of our babies when we scan are going to be cephalic, you know, especially in the third trimester. So fetal spine to the right, fetal right side is down, because you need to know where the situs is. Where is the stomach? Is the apex of the heart? Are they on the correct side? So you need to understand what side is the fetal side, what side is left, what is right. Documenting that heart. We want to do the time motion motor, M mode. You're going to, it's a linear cursor. We're going to place it over the two-dimensional image and produce a tracing over time. The embryonic heart rate is first seen about 5 to 6 weeks gestational age. Mean range is 100 to 115 in the beginning, maybe as low as 80. If it's less than 100, that's the one that needs to come back in a week or 2 weeks to follow up. If it's in the normal range, you don't need to follow them up until, you know, their next OB appointment. Variable heart rate ranges from different sources, references. These are the guidelines that we're using. Now, that heart rate peaks at 8 to 9 weeks at about 170 beats per minute, plus or minus 20 beats either side. And the second trimester, the range that we're using is 120 to 180, and in the third trimester, 110 to 160, because that heart, as it becomes a bigger, more efficient pump, then the normal ranges do come down. So when we're looking at the heart rate and rhythm, the most common arrhythmia that we see is going to be PACs, premature atrial contractions. 75% of them, of arrhythmias, are going to be PACs. Sometimes it's from maternal, too much caffeine that they're taking. Sometimes it's maternal stress. There's different things that can cause these little things. Most of the time, they're not going to develop into a problem, but we follow these, if we document these PACs, because they can turn into SVTs, supraventricular tachycardia, and then that's something we can treat in utero. So in the early second trimester, when we're scanning, doing our survey, the SA node is not very mature, so you can cause this sinus pause, where the heart stops for a brief moment. It's a normal variant. If that happens when you're scanning, move away, or you're going to freak the patient out. If you're pushing and all of a sudden the heart just stops, mom's eyes, I mean, it's like pulling them off the ceiling. They're a little nervous. So if you see it, move away, decrease your pressure. Sometimes, you know, we're concentrating on trying to get the best image, so we're pushing a little too hard. So back off on the pressure, move away, go measure something else, and then come back. All right, so I'm going to start looking at our survey. We're going to start over here on the right side. And we're documenting where is the placenta, we're looking at the uterine wall. Then we're going to move towards midline. So now this is the right. But now we see placenta here. We're starting to get amniotic fluid. Now we're midline down low, looking at that cervix. Midline high up towards the umbilicus. Again, documenting how much fluid is there. Moving over toward just to the left of midline. This is where we're seeing the majority of the baby. If this is sagittal, then this would be baby's head position is cephalic, head down, little tushy, bladder up. And now I'm going more over towards the left. And we scan transversely, again down by the cervix. And we're just going to, in little steps, just move up. Now we can see where the head is at. So from the cervix, the next thing I saw was the fetal head. And I'm looking at the adnexal areas, trying to make sure that there's no big fibroids, adnexal masses, heterotopics, especially with your IVF patients. There's an increase of heterotopics where there's a pregnancy in the uterus and outside the uterus. So you want to make sure that, especially in the first trimester, that you're looking for that. And then again, where is the placenta? So we're at the midline now, right by the area of the umbilicus. Now we're moving up towards the top of the uterus. And then the cervix. Okay, so don't measure the cervical length with a full bladder because the bladder compresses the cervix, which elongates it. Full bladder hides funneling of the internal loss, and it distorts the location of where the placental margin is at. So a good thing is if you have a table that tips a little bit Trendelenburg, you can tip mom a little bit, kind of pulls the baby's head or whatever fetal parts are down there up out of the pelvis, and then you can come up higher towards the umbilicus and angle back. So you're actually using amniotic fluid to look at the cervix. If you still can't see it, then you need to proceed to transvag. And having the rapid hydration can irritate the cervix, causing these little myometrial contractions. So you can make it look like the anterior wall of the uterus and the posterior wall are contracting together, and then it starts to relax, and then you think it's incompetent cervix when actually the cervix is lowered. It's just that little contractions that you're seeing. So there's a lot of little variants that can fool us while we're scanning. So the most accurate cervical length is by a transvaginal scan. Most of the cervix you can see transabdominally. If you cannot clearly see it and make sure that no placenta is over there, you're obligated to go ahead and do a transvag. So here's the endocervical canal here. So this is just using that amniotic fluid. You can see there's no full bladder. We don't fill any of our moms for any scans. We stopped doing that a long time ago. So if you're filling the maternal bladder, stop. We're just using amniotic fluid. We've tipped the bed Trendelenburg, kind of lets the baby float up a little bit using gravity as our friend. When we're scanning here, we're using amniotic fluid to assess that cervix. Another patient, we couldn't see the cervix well, so we're doing the transvaginal. So we're coming in here. Here's the external os. There's the endocervical canal. What's this? You're going to see it all the time. Napoleon cyst, yeah. Don't freak out. You're going to see them all the time, especially with the resolution of the transvag that we have now. Okay, cervical length, normally we want to see greater than 25 millimeters in the second trimester. I just want to point out that if you're doing a transabdominal, make sure that you're not including part of the vag cuff here. You don't want to include that in your measurement. You want to do just the cervical canal. Okay, estimate of the amniotic fluid volume or index. You can do a qualitative or subjective. Just look in and say, yeah, I see a normal amount of fluid. Once you've been scanning, you can see that. We usually don't start doing AFIs until after 24 weeks. You can do a semi-quantitative measure, measuring your deepest vertical pocket or maximum vertical pocket, single vertical pocket. It's all the same thing. It's an AP from mom anterior to posterior. You don't want mom tipped. You don't want any fetal parts in there. Or you can do an AFI. So qualitative, just looking around. Now, just looking at this one, I don't think anybody would miss that that's just too much fluid there. And the other thing you notice is, look, when there's extra fluid, look how it really thins out that placenta. And the baby's just kind of pushed over to one quadrant or not, or the other. I mean, they're like in the Olympic-sized pool, just moving around there. If you can see things too clearly, it's probably too much fluid, unless they're only 90 pounds. And if you're having a really hard time seeing the fetus in the second trimester, then think maybe there's not enough fluid. And that's when you want to start looking at, maybe I need to measure this fluid instead of just doing a subjective. All right, semi-quantitative is when we're measuring the deepest vertical pocket. Again, same thing as MVP or a single deepest pocket. Greatest vertical dimension of the free fluid with the transducer perpendicular to the floor. You can't come over to the side and angle all the way to the middle of the abdomen. It has to be straight up and down. Oligohydramnios is if you have less than a 2 by 2 centimeter pocket, and then polyhydramnios is greater than an 8 centimeter pocket. So this is that deepest vertical pocket. And every once in a while, we'll have one of my docs will say, well, you know, if it's only a 2 by 1 pocket, you don't count that. That's too thin. That's not enough fluid. It needs to be at least a 2 by 2 pocket. So if you're going to use this measurement, make sure you're getting both an AP and a transverse measurement. Okay, the semi-quantitative was developed in '87 by Phelan, Moore, and Kale. It's amniotic fluid index. You're going to take the maternal uterus, you're going to divide it into 4 quadrants. You're going to measure the deepest pocket in each of those quadrants and add it together. Now there's different charts, so decide what charts you want to use for your lab and make sure everybody's using the same charts. The ranges are going to vary for gestational age, and the range we're using for this is oligo if it's less than 5 and poly if it's greater than 24. So we're taking our maternal uterus, dividing it into 4 quadrants, measure the largest pocket of free fluid in each of those quadrants. And if you have the little 4-on-1, it's nice to be able to see all of them on one image. And this is Moore's chart. So again, you can see by each gestational week, you can see how it changes. All right? So what is amniotic fluid? Well, fetal urination begins in the first trimester. By 16 weeks, 70–80% is from the fetal kidneys. So if you see normal fluid at 14, 15 weeks, that doesn't mean that there's not a renal agenesis, because that fluid can be coming from other components. You could still have normal appearing fluid earlier on. By 16, 17 weeks, you start to see, oh, no fluid. By 18 weeks, baby's producing 7 to 14 cc's per day. By term, a fetus is voiding 600 to 1200 cc's per day. And the urine production slightly exceeds what's being swallowed. So it's like a big recycling factory. You're getting blood from the placenta to the kidneys are making the urine. If the whole GU system is working properly, baby pees it out, they're swallowing it, practice breathing with it, moving around. As long as the brain's telling the baby to move and swallow, it should be a fairly even normal amount. So what's in it? We have stuff from the skin, we have from the placenta membranes, we have from fetal swallowing, intestinal reabsorption, just one big recycling factory. So the fluid production is from the kidney, skin, lungs, membranes, and cord. Removals from the GI tract, the lungs, membranes, and cord. So AFIs are extremely subjective. They vary from person to person. You can have the same person on the same machine with the same patient measure an AFI at the beginning of the exam, at the end of the exam, and they're going to get different numbers. So if it's off by 2 to 3 centimeters, pretty much the same. Some of the patients get very stuck on, oh, it was 10 and now it's 9. Baby puts the hand in the middle of the pocket, it's 9. Baby moves the hand out of a pocket, 10. So remember, it's not an exact science. And you don't want to take 20 minutes to measure an AFI. You can measure the same amount of fluid being moved around from one quadrant to the other. It should be fairly quick. So if you're having a hard time trying to make sure that there's no cords, you can use color. If you don't have color in your machine, just turn up your overall gain, and you'll be able to see the blood moving through the cord. That's the biggest thing we see is people measuring pockets that they think are fluid, and it's actually umbilical cord. So if you have color on your machines, use that. Take your multiple measurements, standardize it within your lab, so everybody's doing this procedure the same way. Okay, I'm going to move on to the placenta. I want to document the position of the placenta and its overall relationship to the internal os. Evaluate it both sagittally and transversely. Document the appearance of the placenta and that it should be appropriate for the gestational age. And then we'll go over more of that in part 2 in the next lecture. Placenta cord insertion is recommended but not mandatory, especially with your multiples. When you have multiple gestations, you have IVF pregnancies, they have a higher tendency to have abnormal cord inserts. So you can have a placenta that's anterior, but you can have a velamentous cord insert and vessels crossing the cervix. I think eventually it's going to be mandatory. It's not mandatory yet, it's just recommended. Okay, Just remember, location, location, location. Everything in the fetal anatomy is all connected to each other, 90 degrees to each other. So if you can get into a plane where you can see that spine or a transverse of the chest with the heart, most people can get that head or the heart. And then from there, knowing how the baby's laying, you know how to adjust your transducer. It's all about pattern recognition. What's normal, what's a variant of normal, or what just doesn't look right and is abnormal. And that's your job, not to diagnose what everything is, but does it look normal? And if it doesn't look normal, well, send it on to somebody who's their job to figure it out. Okay, the biometry. We're going to look at BPD, the biparietal diameter, the head circumference, the femur length. I really suggest that, again, it'll be something that's not mandated, but probably will be in the future, is looking at the humerus length, because it's actually more sensitive than the femur length for picking up some of your early Down syndrome. And it's very easy to do. I mean, you used to do in a femur, just go up and do the humerus. And then the abdominal circumference. We're going to look at the anatomy. We're going to look at the head, neck, face. We're going to look at the cerebrum and cerebellum, the choroid plexus, the falx, the cisterna magna, lateral ventricles of the cerebrum, and then the cavum septum pellucidum. This one's very important. We'll talk about that. And then the nuchal fold and the upper lip. So the fetal head. There's 3 different planes that we want to look at in the fetal head: the ventricular, the thalamic, and the cerebellar. So we're looking at the ventricular view, that's up higher in the head, and what we're looking at is both lateral ventricles. So you want to be able to see the midline falx, and then the choroid plexus with the lateral ventricle. In the transthalamic view, we want to see part of the falx and then into the thalamus, and then the cerebellar view, we're just taking it, we're seeing the cavum septum pellucidum, we're angling posteriorly so that we can see cerebellum. This is 4th ventricle here, and this is vermis and cisterna magna. We'll look at each of these individually. So the biparietal diameter and head circumference are done on this transthalamic plane. So even though you're looking at 3 different planes, where we're getting our measurement is going to be on the transthalamic. The normal head shape is oval. You shouldn't have a round head. A round head is a sign that there's a problem. So it should be a nice oval shaped head. So we're going to look anterior to posterior, so front to back. This is looking at the skull. This is looking at part of the falx, and then we want to see the cavum septum pellucidum, the little interruption of the falx. Then looking at the thalamus, and then back to the falx. So when we do our BPD, we're doing, this is the only measurement we're doing from outside to inside. Everything else is outside, outside. So the outside of the skull to the inside of the skull. That's your BPD, biparietal diameter. These are some of the images. So we're looking at cavum septum pellucidum, should look like a little rectangular hypoechoic space. I don't want to say cystic, but it's a hypoechoic space. So an area that interrupts the falx. Because when you're looking at the ventricles, see, here's the lateral ventricles, the falx should be all the way across. So when you see cavum septum pellucidum, it should be a little rectangular box interrupting the falx. So this is going to be your transventricular. This is your transthalamic. This is thalma here. These are the bright areas are going to be the choroid plexus. And like anything that's paired, they should look similar. So if you want to assess the ventricular size, make sure that they look similar to each other. And then from this transthalamic, transventricular, we're going to go to the transcerebellar. So we want to keep the cavum septum pellucidum in view. And now I'm just angling, tipping my transducer posterior in the baby's head. So now I'm coming cavum septum pellucidum, thalmi. These things that look like little arrowheads are going to be the cerebral peduncles. Just looking at the tentorium, both hemispheres of the cerebellum and the cisterna magna, which is the reservoir for the cerebral spinal fluid. This is very important because when you have a neural tube, an open neural tube defect, you have leaking of CSF fluid. So you have obliteration of the cisterna magna, and then the cerebellum gets pulled down low into the back of the skull and gets an abnormal shape to the cerebellum. So it's important to get all 3 of these views. Okay, head shape, pay attention to it. So brachiocefalic when it's too round. and dolichocephaly when it's too elongated. Now this can be a variant, either of them can be a variant, especially in the third trimester, but in the second trimester, they should be pretty much just oval. If they're too round, think of aneuploidy. If they're dolichocephaly in the second trimester, start looking at that fluid because something is compressing that baby's head, that skull. All right, your biparietal diameter is measured at the level of the thalmi and the cavum septum pellucidum. I just want to make sure that you know, we talked about it should be a hypoechoic or cystic appearing space that's interrupting the falx. Make sure you're not getting the one with the 3 lines because that's a little bit too inferiorly, and that's actually the columns of the fornix. So you want to make sure that you do see the cavum septum pellucidum. You see the 3 lines, that's the columns of the fornix. You're just a little bit inferior on the baby's head, just come up a little bit higher. So there's that nice cavum septum pellucidum. See, it looks like a little rectangular hypoechoic space, interrupts the falx. That's where you want to look. BPD from the outside to the inside, and then the head circumference, just putting a tape measure around that head. So those 2 measurements are done on that transthalamic view. Lateral ventricles. We're looking at the posterior horn of the lateral ventricles. We don't measure at the anterior horn, the posterior horn, and that transventricular view. It's also known as the atrium of the lateral ventricle, and that's where the glomus of the choroid plexus, or the bulk of the choroid plexus, lies. And the choroid plexus make and reabsorb the cerebral spinal fluid. So it should look brighter, more echogenic. The normal measurement for the posterior horn of the lateral ventricle, also known as the trigone or the atrium, should be less than 10 millimeters throughout pregnancy. It looks more prominent earlier in the pregnancy because the cerebrum is not that developed. So the cerebrum, as it's developing, is giving more outline, more definition to the lateral ventricles. It's going to compress them as the cerebrum develops. And these are the choroid plexus. See, looking at that falx, straight up and down. Choroid plexus, choroid plexus. And then we try to document both sides. So we see right side and then left side. So presence of or absence of cyst. That's what we're looking for. Does it look bright? Or does it look like it has these little cysts in them? So choroid plexus cysts by themselves, if they're isolated and the woman is not AMA, by themselves, it's a variant of normal. We see them a lot. We used to all panic, send them for all these tests, follow them up, and we found out that as long as we're not seeing anything else, it's a variant of normal. The highest association with choroid plexus cyst, especially bilateral and large, is going to be trisomy 18. So if you see that, start looking at the heart and the hands, because 90% of babies with trisomy 18 are going to have a heart defect. But if you see choroid plexus cyst, really look at the hands, the heart, abdomen. If you see anything that doesn't look normal, they need to be sent out for evaluation. So transventricular plane. So when you're looking at that ventricular plane, the one on the left and the one on the right, which one's normal? Because look, there's the choroid plexus, and the walls of the lateral ventricles should kind of hug that choroid plexus. Look at this. That's your job to know that this is normal, this is not normal. Look how round that head kind of looks, that the head looks there. So this is all dilated ventricle, and you can see the choroids kind of dangling in there. So that's what you need to know. This is normal, this is not normal. Okay, that cavum septum pellucidum again makes up the medial walls of the lateral ventricles. Rectangular, hypoechoic. If you don't see that, that could be a clue that there's something going on with the corpus callosum, because the corpus callosum gives that roof to the cavum septum pellucidum. So if you don't see it, again, they need to be referred. That's why I was telling you the difference between the 3 lines and that nice hypoechoic space. So really pay attention to this. Okay, the transcerebellar plane. Correct angle, so we see the cavum. We're looking at the falx, all the way back to the cerebral peduncles, look like little arrowheads, just kind of pointing back to the cerebellum. The vermis connecting both hemispheres of the cerebellum. We don't want to see a wide splaying between these 2 hemispheres of the cerebellum. And then the cisterna magna. And the normal cisterna magna should be 2 to 10 millimeters. See, thalmi, cavum septum, cerebellum, vermis connecting those 2. Now, if you're trying to evaluate the vermis of the cerebellum connecting both hemispheres, before 18 weeks, it's not completely formed. So it may look like part of it is missing. It just hasn't completely finished. So don't try to evaluate the vermis before 18 weeks. Okay, cerebellum is important for coordination of voluntary movements and for learning motor behaviors. Again, cavum, thalmi, and pattern recognition, pointing back here to the cerebellum, connected by the vermis and the cisterna magna. That cisterna magna, again, is posterior to the cerebellum. It's filled with cerebral spinal fluid. The normal range, 2 to 10 millimeters. And so on this transcerebellar view, we've got the cavum, we've got the cerebellum. This is where we're going to measure. So from the vermis to the inner skull table. So this is known as the posterior fossa. This is normal. This is not normal. And that's all you need to know. Does it look normal? Pattern recognition. Does it look normal or does it not? And if it doesn't look normal, what else do I see? The more things you see, the greater the chance that there's something globally going on, either a syndrome or aneuploidy. All right, nuchal thickening. It was first described in 1866 for trisomy 21 or Down syndrome. First ultrasound marker to be described and universally used. It's very sensitive, 20 to 40%. That's one of our best markers, is only 20 to 40%. So keep that in mind. Can be seen in association with heart defects also. People think, oh, if I've got that thickened nuchal fold, it's automatically Downs. Nope. It can be Downs, it can be Turner's, it can be a heart defect, it can be a variant of normal. You can see it in twins. But remember, just because you see it doesn't mean that it's automatic. This is recommended that we measure this from 14 to 18 weeks. It should be less than 5 millimeters. From 18 to 21 weeks, it should be less than 6 millimeters. It's still the single most sensitive marker for picking up Down syndrome. And this is done on that transcerebellar view, cavum, looking back here by the cerebellum, right here where we were looking at the cerebellum, the vermis cisterna magna. Well, now we're going to look from the outer skull table to the outer skin surface. That's where you're going to measure your nuchal fold. So that nuchal fold thickening is just a redundant skin at the back of the neck. It's measured at the level of the cerebellum with the cavum septum pellucidum in view. It's an axial section of the head, and calipers again from the outside of the skull to the outside of the skin. Abnormal, greater than or equal to 5 from 14 to 18 weeks, and then after 18 weeks, greater than or equal to 6. So you can see, just looking at this, you could tell that those look thick. But you have to make sure you're in the proper plane, because I can make every normal baby look abnormal by changing my angle. So that's why I'm telling you, really look at that cavum septum pellucidum, where you can see the cerebellum, see the cisterna, because I can make every baby look abnormal. It's an artifact of the ultrasound, the way you're angling. Profile nasal bone, it's recommended, not mandatory. It's currently thought to be as sensitive as the nuchal fold for the detection of Down syndrome. So this is one of the first things that's come along in a long time that is almost as sensitive as what the nuchal fold is. And what's great about looking at the nasal bone, where with the nuchal fold, after 21 weeks, we really don't look at it anymore because we don't know what it means. It's, you see it in too many of the normal population to really have any data on that. So, but this, the nasal bone, you can look at it throughout pregnancy. You can look at it in the first trimester, presence or absence. Then when we get to this stage, you can do a BPD nasal bone ratio. If it's greater than 10, then it's abnormal. So what we need, though, is we need to be able to see, this is cavum septum pellucidum, this is corpus callosum here. So it's right at a profile, baby's got to be looking up, and this is that nasal bone. So absent nasal bone reported to be 70% sensitive for trisomy 21 in the first trimester. So absent. It's usually seen by 12 weeks, so don't start looking at it at 10. You're not going to see it. And the second trimester can be short or absent, and there's where we get to that 40%, which was as good as what the nuchal fold was. 40% sensitive for Down syndrome in the second, 70 in the first, but only 40 in the second. BPD nasal bone ratio is independent of gestational age and maternal age. So this is the woman that comes in at 28 weeks, maybe, She's not had any genetic screen. She's late prenatal care. And this is one of the things you could be looking for. You know, what do I offer her? What's available? Well, if I'm seeing an absent nasal bone, I think NIPT is going to look pretty good. You know, there's a limit to what you can see, but at least this gives you something you can look at to help you screen for some of these genetic problems. This is looking at that profile. So there's 24 weeks. So again, mouth open a little bit here, but there's that nice nasal bone. All right, so 11 to 14 weeks, presence or absence, combination with the maternal age and nuchal translucency, it can increase your sensitivity to 85%. 15 to 20 weeks, you measure the length, shorter in Down syndrome. So a ratio of 9 detects 100% of Downs, but it gives you a lot of false positives. So that's why we went to 10. So you take the BPD in millimeters divided by the nasal bone in millimeters, it's going to give you a percentage. Now this is just looking at the upper lip and nose. So now, if I'm getting my BPD and now I want to look at the lips, turn 90 degrees, drop your angle down, and then you're looking from the chin up into the lips. They do want you to make sure that you look at the lips and nose. So from the profile, 90 degrees. Just looking at the lower lip, upper lip, and we want to see two nares, because sometimes you can have babies that have a kind of an abnormal nose with just one nares. If you have 3D in your office, if there's good fluid, 3D is wonderful as long as you have fluid. Again, that's not mandatory. Little profile. You look at ears, orbits. You should be able to see, if you have two orbits and there's normal spacing, you should be able to put a third orbit right inside. If it's too far apart, they need to be referred because they may have hypertelorism. If they're too close together, then you think of chromosome problems where it's hypotelorism. But this is looking at the bony parts of the eyes, the orbits, and then these little bright areas are the lens of the eyes. You guys aren't required to look at that, but we look at them because if you have congenital cataracts, that can go along with different syndromes and chromosome abnormalities also. But just remember, when you're looking, if that baby's got the head up, just look at the orbits, make sure that you do see two and that there's normal spacing. You should be able to put another third orbit right in the middle. And those are the lens of the eyes. Okay. So we looked at the head, we looked at the face, we're going to move down into the chest and heart. So your basic cardiac exam includes a 4-chamber view of the heart, and the views of the outflow tracts are now required. They used to be just, if you can get them, go ahead and get them. Now they're mandating. Again, that was a 2014 update. So you have to look from that 4-chamber and get those outflows, make sure that they're crossing each other. Because with that 4-chamber, just the 4-chamber alone, you're only going to pick up about 50% of heart defects. Adding the outflow tracts raises it to 80%. So it makes a big difference. And what's the most common congenital abnormality? Heart defects. What are we at the worst at picking up? Heart defects. So if you guys don't see it, it never gets to a perinatal center. So we're trying to get everybody to look at those 4 chambers and the outflows. So we want to count how many chambers we have. We want to look at the contractility. We want to look at the size of the heart to the chest, the chamber sizes. Both ventricles should be similar in size. Both atria should be similar in size. What is the cardiac axis? Where is the apex of the heart pointing in the chest? And then looking at the descending aorta. So normal situs is we're going to look at where is the baby's right and left. So that's why we need to know what is the baby's right and left. Then we need to know that the stomach and the apex of the heart are both on the left side. So this is going from posterior to anterior. The apex of the heart points over towards the left. It should be usually at a 45-degree angle, but it can be plus or minus 20 degrees. And it normally occupies about 1/3 of the chest, 33%. All right. Usually my first clue, your first clue that there's a heart defect is if this cardiac axis is off. Usually that's, I mean, I'll look at a heart and I'll go, oh, I don't know what the defect is right now just by looking, but I know there's a defect because the heart, is pointing over here or the heart's pointing over here. So look, just getting used to how that heart should normally be in the chest is going to help you immensely picking up these heart defects. So when we look at this, the right ventricle should be closest to the anterior chest wall. The left atrium should be closest to the fetal spine. 70 to 80% of your heart defects have an abnormal cardiac axis. And did you see when we started, the heart was not as big because we were just surveying the chest? Then you magnify up on that heart because now you're focusing in on the heart. So you need to watch it over time. There's the LVOT. It's the ascending aorta coming out of the left ventricle, but look at those 4 chambers there. And when you're looking at the 4 chamber, the thing you should be paying attention to is this is the descending aorta. It should be just to the left of the spine. If you don't see this here, then you have to worry about a right aortic arch or something else going on. Just to the left of the spine should be the descending aorta because it comes up out of the heart and then down. So what are we looking at? We're going to look at the 4 chamber LVOT, which is looking at the ascending aorta coming out of that left ventricle. Then from the 4 chamber, I'm not moving. Because remember, the size of the heart at this time is about the size of a quarter or a little less than a quarter. So the biggest thing I see when people are scanning with me is that they're moving everywhere. Once you see that heart, stop. And all I'm going to do is I'm going to tilt towards the baby's head. That's all you're doing. So LVOT should be the first vessel that I see coming off. And then as I continue to tilt up, then I should see the main pulmonary artery coming out of the right ventricle. And from there, it goes into this 3-vessel view. So 4 chambers, without and with color. The color, if you have it on there, put it on there just to make sure the ventricular septum looks good, the interventricular septum. Then looking at the LVOT again, with and without color, making sure that the aorta and the continuity of the interventricular septum is intact, and then the main pulmonary. And when you're learning how to do this, the people to practice on are your 3rd trimesters because the heart's bigger. It's easier to see things just to get the eye-hand coordination down. But from the 4 chamber, tilt, tilt. That's all you're doing. All right, so your 4 chamber view. Again, the right ventricle, left ventricle, right atrium, left atrium, and then there's the descending aorta. So they should all be fairly equal in size, looking at that interventricular septum, and with color. Just documenting the flow. And you can see there's my descending aorta over there. So right ventricle closest to the anterior chest wall, looking at the ascending aorta coming out of that left, and then the main pulmonary coming out of the right. So echogenic foci. So EIF, EIE-IO. EIF, IEF, however you want to call it. It's just a bright echo within the ventricle. It's most often on the left side, maybe singular or multiple. If isolated, consider the variant of normal. Again, a lot of things, just like the choroid plexus cyst, these things you see them all the time. If you're not seeing anything else, the key is you have to make sure you look at everything else. As long as you're not seeing anything else, it's a variant of normal. Now, if you have EIF and mom's AMA, they need to be referred. They can't have any other risk factors. Yep, advanced maternal age, yes. Sorry, yes, yeah. So 35 or older at the time of delivery, so even if they're 34, going to be 35 when they deliver, then that along with echogenic foci, they should be evaluated. Okay, the right ventricle may be 20% larger than the left ventricle. In the 2nd trimester, this can be an early sign of a coarc. So we do look at the size of the right to the left ventricle. In the 3rd trimester, it's just a normal variant. So again, what am I looking at? When am I looking at it? Because the heart anatomy and renal anatomy, head anatomy, they all change as we go from one trimester to the next. So in utero, the RV is the dominant ventricle. The rhythm. So we're going to measure the movement, recurrence of action, of function at irregular intervals. All of this is controlled by that SA node, the sinoatrial node. Then you have the atrial contraction, ventricular feeling, and then ventricular contraction. So this is how, if we're looking at the interventricular septum, anytime you want to look at the septum, I know everybody loves to have that apex up, that's great for getting your heart rate, but when you're actually trying to look at the integrity of the septum, you want it perpendicular to your beam, because that's when you're going to get the most information, is when your beam's coming in and it's what the structure you're looking at is perpendicular to that. Okay, the SA node is a microscopic collection of atypical cardiac muscle fibers. It's located in the right atrium at the junction of the SVC. It's known as the pacemaker of the heart. An electrical impulse is sent from the SA node to the AV node to the ventricles. The AV nodes act as a pathway to the atria and the ventricles. It carries the electrical impulses through the bundle of His, divides into the left and right branches, and the impulses travel from that apex to the bundle branches. And the contractions move the impulses through the myocardium via Purkinje fibers. That's a whole nother lecture. I just want to make sure that you guys understand how that is working, and that the SA node, especially in the second trimester, you're going to see some of these little irregularities. Roll the mom on the side, go look at something else, come back to it. So to evaluate the outflow tracts and great vessels, you're going to locate your apical 4-chamber view, and then you're going to sweep the beam towards the fetal head and passing through the ventricular outflow tract. So just stop, get your 4-chamber, and actually just tilting or sweeping. Not moving, sweeping. Okay, so your job is to know, does that look normal or abnormal? Yeah, because when we're looking at that 4-chamber view, those valves should be offset. The tricuspid valve should be a little bit more apically displaced towards the apex. So when we see, look at this big gap here, and look when I stop. When you're looking at it, if the valves are straight across, there is a problem. They shouldn't be straight across. They should be offset a little bit. Okay, so looking at the fetal abdomen, we need to document this. The stomach is on the fetal left, which is called situs. That's what we're looking at. We'll put a transverse of the heart and the stomach on one view, a split screen, documenting situs, that both the apex of the heart and the stomach are on the left. We need to identify that there's the kidneys. How many kidneys do I see? Are they in the normal position? Because remember, the kidneys start embryonically, they start down by the bladder, and then they start to ascend up, and then they rotate around. So, I mean, there's a lot of movement going on in the kidneys, and if there's any interruption of that normal development, you can find kidneys in the pelvis, you can find them fused. There's so many different things you can see. You need to see that the bladder, I like to look at the bladder and the stomach when I first do my survey to assess the size, because it should change during the time that you're scanning. You want to look at the umbilical cord insertion site into the fetal abdomen. You want to count how many vessels are in that umbilical cord. So abdominal circumference, we're looking from anterior to posterior. We do not want to be able to see the umbilical vein all the way to the fetal abdomen, because then we're oblique. We need to be up at the area of the liver. So we're going to look for what's called this little J hook here. That's looking at an umbilical vein going to the left portal right before it divides into the portal system. Because in utero, this is all the left lobe of the liver. In utero, the left lobe of the liver is the largest part of that liver. The abdominal circumference should be determined at the skin line of the true transverse level at the junction of the umbilical vein to the portal sinus and the fetal stomach. So there's stomach. So we want to see just this little J hook, and it should be angling away from the stomach. It should not be coming back towards the stomach. If it does, that's a persistent right umbilical vein. Because in the beginning, there's two arteries, two veins. Almost always the right umbilical vein collapses. If something happens to the left umbilical vein, then the right stays open. This is what, and this can be outside measurements. So we're going to put our caliper here, use our ellipse. So it's just like putting a tape measure around the baby's tummy. So if you're not sure how this is flowing, throw your color on there or turn up your overall gain. Okay, there's two hypoechoic structures in the fetal abdomen, the stomach and the gallbladder. I've seen this time and time again where people are calling the gallbladder the stomach. The gallbladder is usually more anteriorly displaced, and you're going to see over by the liver. But I mean, you have to assess it, look at it, check the situs, make sure that you have correct and left orientations, because there are some anatomic problems where your situs inversus, where you have the stomach on the right side. So, you know, you want to make sure that the stomach is on the correct side. Stomach's more dynamic. You should see it filling and emptying at least once during your scan. So look in the beginning, look at the end, make sure that it has changed in size. So we talked about situs. You want to use your split screen. And what situs is making sure, again, that we know what's left side and that the apex of the heart is pointing towards the left and that the stomach is on the left. You can look at looking at the bladder and the stomach on a coronal view. I like looking at this one because I can look from the clavicles all the way down to the pelvis. It lets me look at the diaphragm, the liver, looking at the bowel, make sure the bowel should not be more echogenic than bone. As long as it's not as echogenic, it's not a marker. If it is more echogenic, that can be a marker for a problem. but then I can see the stomach and I can see the bladder. So I think as you start scanning, you'll get to like this coronal view. So anytime you have bowel that's less echogenic than bone, that's normal. If it's increased, it can be seen with infections, swallowed blood, cystic fibrosis. So sometimes our earliest sign that the baby has a CMV infection or mom's been exposed to CMV and this baby's at risk is the echogenic bowel. All right, and remember now the stomach changes, especially in the third trimester. You can have all different sizes, shapes. Sometimes if there's been some bleeding earlier in the pregnancy, baby can swallow that and you can get blood in the stomach. So it can look kind of unusual at times, but just make sure that it's moving and that you're not seeing a double bubble because that's a problem. That's where a duodenal atresia may be occurring. You need to know that this is not stomach, this is ascites. So again, just pattern recognition. What should I be seeing? Where is it at? Does it look normal? These are liver calcifications. Again, too bright. It should not, if it's bright as bone, it's not normal. In the fetal abdomen, it should not be as bright as bone. Diaphragmatic hernia. Well, here we have stomach and the heart's pushed way over towards the right side because we have a defect on that left side. So we look down at the abdomen, we couldn't find our stomach in the abdomen. You start coming up into the chest and diaphragmatic hernia. So this is intestine and stomach on the left side of the chest, heart being displaced over into the right side of the chest. That was looking transversely, and here's that coronal view. Because look, here's my diaphragm, there's my bladder, my stomach should not be up here in the chest. So it's just pattern recognition. Sometimes in the third trimester, you'll see these, especially with your females, you're going to see these cystic areas. Until proven otherwise, usually it's not bowel, it's usually an ovarian cyst, but just make note of it and have them follow it up. Okay, kidneys, number and location. We want to look at the renal pelvis because again, this can be a marker for some problems. So up to 20 weeks, we want to see the renal pelvis, less than 4 millimeters. From 20 to 30 weeks, less than 5 millimeters. After 30 weeks, less than 7 millimeters. So we want a cross section of the baby's abdomen. And we're going to look at the spine, and then on either side of the spine, we should see the kidneys. Now, earlier on, they're hard to see just because there's not really any perinephric fat yet. So they are very hard to see. But this is what we want to see in the renal pelvis, is right where the ureter is inserting into that central collecting system, draining the urine out of the kidneys. Sometimes you can use that coronal view and put some color on. Helps to identify the kidneys a little bit because they are hard to see, especially on your larger patients. So they have these different maps and stuff, these color maps that help to look. You look at the sepia, the blue, all of them will help you when you're having a hard time. The other thing you can do is put on color flow. So this is a coronal view again. So looking at the descending aorta all the way down into the iliacs, but now I can see my renal arteries. This patient had lower fluid, and I was just having a hard time. See, throw on your color, man. And then it'll help you. Oh, I know there's kidneys there because I can see these renal arteries. So these are all these little tools that you have on your machine that can help you. We'll go down to the fetal bladder. It's an anechoic structure. Fills and empties every 30 to 45 minutes. So that's what I'm saying. Look at the stomach, look at the bladder. It should change size during the time of your scan. So you just want to look at the location and the size. And then we will look at the umbilical cord insertion into the fetal abdomen. So this is a sagittal view of the umbilical cord coming in and then transverse. This is important because we want to make sure that there's no defects where the cord is inserting into the fetal abdomen. So again, using that color, so we can see the cord here. We want to make sure that there's no defects, especially to the right of the umbilical cord, which would be a gastroschisis, or where there's a herniation of abdominal contents into the base of the cord. So these are just looking with and without color, looking at that cord insertion, paying attention to that anterior abdominal wall. So fetal cord insertion is separate than what bladder with the vessels around are. Those are two separate views. All right? So number of vessels in the umbilical cord, now we're going down into the bladder. We should see when the cord comes in, higher in the abdomen, umbilical vein goes up, and the umbilical arteries are actually coming off the baby's iliacs, wrapping around the bladder, and then bringing the blood back through the cord to the placenta. So you should see both umbilical arteries around the fetal bladder. There should be two arteries one vein and two arteries. Sometimes you'll see a single umbilical artery. A lot of those babies do fine. Sometimes we don't even know that they have a single umbilical artery until they deliver, if nobody looked. Those babies have a higher association for kidney abnormalities. So you want to make sure that you do look at the kidneys. And then there is an association with single umbilical arteries with some of your aneuploidy and some of your syndromes. So again, if you see one abnormality, start looking for others. But the highest association with single umbilical artery would just be renal abnormalities. Okay, the abdominal wall defects, when we're talking about the cord, the two main ones that we look at, we won't go into all of them, but let me just gastroschisis, omphalocele. So gastroschisis is about 1 in 3,000 births. It's a small defect to the right of the cord insertion. So here's where that cord's coming in. I've got my color here. There's that defect, and so you have small bowel herniated through the defect. So you can have, usually it's just small bowel. Sometimes it can be small bowel, large bowel, part of the bladder, the kidneys. All the abdominal contents are pulled down, so the stomach is actually sitting down in the middle of the abdomen. So it all depends upon what's herniated through this defect. There's no membrane over the bowel, and it has a very low association with chromosome abnormalities. When you compare it to omphalocele, it's 1 in 4,000 births. You have abdominal contents herniated into the base of the cord. So that's why we're looking for that cord insert. See if there's any hernias or defects, anything herniated into the base of the cord. It's usually bowel and liver. It's covered by a membrane. It's associated with cord cysts, has increased Wharton's jelly, and has a high association with chromosome abnormalities. So gastroschisis, some of these babies, when they come back, 4 or 5 weeks after the surgery, you can't even tell anything was wrong. They do wonderful. But the omphalocele, that's a whole nother story. But so here we have, again, the cross-section of the abdomen. See how the stomach's pulled forward because you have some abdominal contents herniated into this defect. Look at all the liver, even stomach's out here. This is what it looks like 3D, and then after the baby's born. Again, this one has the higher association with chromosome defects. And with omphalocele, a large omphalocele versus a small omphalocele, it's actually the smaller omphalocele with just bowels sitting into them have the higher association with chromosome abnormalities. So some of the pitfalls we get to, especially in the third trimester when we're pushing, trying to get that good abdomen, is we can make this look like an omphalocele, but it wasn't. It was just from pushing too hard. And there was lower fluid on this lady. So you can make it look like there's an abnormality when there really isn't. See? This one was because of a little contraction. The uterus had a little contraction. It made it look like an omphalocele. And I'm like, well, how come nobody saw this before? Well, contraction goes away. Good thing about contractions, they always go away. You look again and, oh, it's normal. All right, spine. We want to make sure we look at the spine in 3 planes: sagittal, transverse, and coronal. The one that everybody's used to looking at is the sagittal. Guess what? That gives us the least information because that's looking at an anterior and a posterior ossification center, and your bifidas are between your 2 posterior ossification centers. So we're still going to look at all the different areas, and this is your sagittal or your longitudinal. This is the view we're always looking at, but look, you're looking at an anterior and posterior element. So you can be angling this way and totally miss a defect. So make sure you're looking in both views. The sepia really helps to highlight those bones. So we're going from the cervical thoracic down to the lumbar, and then lumbar down to the sacrum. This is actually, so the bony parts are the vertebral bodies. The actual cord are these little lines here in the middle. So the best view for picking up spinal defect is going to be transverse. You sweep the transducer from the cervical area all the way down. Most commonly, your defects of the spine are going to be in the lumbar sacral area. So you should have the anterior vertebral bodies and then the 2 posterior with skin covering over it. This one, you can see how these are widened and then there's no skin covering over there. So that's what we're looking for. So actually the transverse and the coronal are the better views, but it's the one that we are least familiar with. Just make sure you're at least doing that transverse. There's the coronal. The coronal view is the only view that you'll see all 3 ossification centers in one plane. Okay, so coming down here, and then what we're looking for is we see that little sac or that little cystic meningocele there. What's going to be your first clue that there's an abnormality in the spine? That head. Because remember, you have fluid leaking So now you don't have a normal cisterna magna, you have displacement of the cerebellum. So the abnormalities in the head tell you, look at my spine, look at my spine. Because sometimes with a flat defect, we can't see it very well, but the head is telling me there's an abnormality. Okay, looking at the extremities, we're going to look at the legs, arms, hands, feet. You guys don't have to document tib fibs, radius and all that other stuff like we do. You just need to document that you saw 2 arms, 2 legs, that there was a hand and a foot attached, okay? So you're looking presence, absence, movement, posturing. So femur, this is where we're looking at the length of the femur. And remember, we're not going point to point. You don't measure to the point. It's the mid-body of the femur that you're going to measure. And if you have a good measurement, you should see the shadowing behind the femur because the bone's stopping a lot of the sound waves, so you should have a shadow behind it. If you don't have a shadow, then it means you're not in the middle of that femur. Okay, so you're looking at the long axis of the femur shaft. It is the most accurate when the beam is insinuated perpendicular. Again, perpendicular. So if the baby's got the leg up and down, you're not going to get a very good measurement. You're going to make it shorter than it should be. You need to either move baby, move mom to try to get a better angle. You want to get it as perpendicular to your transducer as you can. Looking at the foot, so we went from the femur, and then femur to the tib fib to the foot. You guys don't have to count the toes, but you need to make sure that there is a foot there. Looking at both forearms and fist. So looking across the chest, those are elbows to the fist. And then if you have 3D, you can throw that on there. I just love the 3D, so I'm throwing them in there for you. Sometimes you'll have the babies that'll go, yeah. And they're like, yeah, quit pushing on me. And then just, yeah. So the color, I think, for the bones really helps to highlight. Kidneys, bones, use that sepia or the blue. It really makes a big difference. And then we'll talk about the 5th mid-phalanx. I mean, that should be nice and straight because that clinodactyly, the little curving in, could be a sign for problems also. This is what you want. When you see a leg coming out, this is not normal. You should not see the bottom of the foot and the extension of the leg in the same plane like this. It should not be curved in. So that's clubfoot. And this one is the clinodactyly. See how that little pinky's turned in? So if you see the hands open or you see the legs extended, just know what looks normal. It either looks normal or it doesn't, and you send it out. And gender. This is what the parents always think, that they're coming for their ultrasound just to tell the gender. But so this is a boy, and so you remember now that the testes are not going to descend until about 28, 29 weeks, so don't start looking for them. But if you're scanning somebody for a BPP at 36 weeks and you don't see the testes, you need to make a note of that undescended testes, okay, because you should see them. Hydrocele in the 3rd trimester are very normal to a small amount. You don't want a massive. And if you can't tell the gender 100%, tell your patient that, because they get very upset if you tell them one thing and you come back and it's different. So, and unless the legs are open, if you can't see, you can't see. So the little labia here, little boy, the little testicle, see a little small little hydrocele. But again, a little tushy, little girl parts, little boy, girl, and then the weight. So currently, even the best fetal weight prediction can give us an error as much as 15%. So even in our best measurements in the 110-pound mom, I mean, you know, you're still going to be off. And all of our charts were made for normal-sized babies. So guess which ones we're off on? The really small babies and the really big babies we're terrible at. So when you're looking at this, though, if the weight is outside the normal range, if IUGR is demonstrated, Doppler evaluation of at least the umbilical artery needs to be done. So your technical checklist, make sure you're using the correct transducer. In your later obese patient, then you're going to have to sacrifice some of that resolution to get the penetration. Change your depth and your focal zone as the baby's moving, depending upon what you're looking at. You're changing it all the time. And use the MAG or the RES when appropriate. And remember, if you cannot see clearly in the 1st trimester transabdominally or the cervix transabdominally, you have to go on to a transvag. This lovely young lady came for evaluation for 1st trimester screening. She's 12 weeks, 4 days. She's a little fluffy, so we're having a little hard time. And I'm like, ooh, that just doesn't look normal. Look at the difference when we go to transvag. Do you see this? So every baby has a nuchal translucency. It goes from the middle of the head to the middle of the back. It's how thick it is. So there's your separation of your amnion, chorion, which is still normal at this time. But this is edema around the baby, and this is a large hygroma. This baby was a trisomy 21. But I mean, just the difference between what you can see transabdominally and transvaginally. Alrighty, so ultrasound is a tool to assess patient and fetal status. You want to make sure you look at mom's uterus and annexa, and I always do that first because otherwise I forget. And then document the position, the fetal position, placental position. Know your limitations, and if you have any problems, ask for help. Know your limitations and send them out.